And so what are some of the common foot or toe or maladies that people come in with?
I mean, we certainly see a lot of ingrown nails. We see heel pain, various types of just everyday fractures and sprains and strains. But I have a focus on neuropathy, so a lot of people kind of seek me out for the neuropathy component.
Mm-hmm. What are some of the common neuropathy conditions that you see? So besides the things we mentioned.
Yeah, and so a lot of it is not, and when I tell, and so if you look at neuropathy treatments, there's generally not a lot that's offered, right? And so you can take Neurontin and anti-seizure medicine. Some people talk about Lyrica or Cymbalta are common ones. That's an antidepressant. A lot of times when you ask about neuropathy to doctors, they'll just shrug and they'll say, well, you can't do anything about it. It's just going to get worse. You know, you can take narcotics if it's really bad. And then just, you know, and the other thing that's, I don't know if I think it's funny, but like they always associate it to diabetes, right? And so diabetes certainly can play a role in that. But it's kind of like, well, you have neuropathy, so you must have diabetes. And if you don't, then they're confused and it's idiopathic. They don't know, right? And so, so Dr. Dalton kind of I guess opened my eyes to the idea that, look, if there's pain, there's a reason for the pain. You just don't know the anatomy well enough, essentially, kind of. And so there's something called RSD, which is basically an advanced pain syndrome, right? But his mnemonic for RSD is really stupid diagnosis. And his idea is like, look, they have pain. There's a nerve that's generating the pain. If you find the nerve, then you can find a way to take away the pain, essentially. And so I think the problem in healthcare and a lot of doctors are just, they're kind of trained that, well, there's nothing you can do. And so automatically they just shut off their brain to the idea that something can be done to help with neuropathy. And a lot of people, so many people suffer from neuropathy. And so in just various levels.
Yeah, I know when I work with clients, I often see when people have any type of nerve issue, if you follow the nerve and look at the length of the nerve, we often think of areas of impingement just being kind of a junction between, you know, and like your pec area for your arm or, you know, your tarsal tunnel. But I often talk to people about how muscles, if they're in a contracted state for so long and they're so tight, they can also compress on nerves as well. And if you start turning off those muscles and teaching them how to let go, it often relieves the nerves and you see a difference in their nerve pain. So I'm very pleased to hear this. Dr. Dalton is really, really challenging everyone to look at the nerves in a different way and see, okay, where is the impingement, where is the compression occurring, not just in the common places that we might think of. That's amazing.
Yeah, I mean, it's pretty interesting. He's a hand surgeon. He's a plastic surgeon, a hand surgeon, and like, so he was doing, so it kind of came about, like, so he was doing he's doing carpal tunnel surgeries on many diabetics that had carpal tunnel. So he'd release the nerve, and they'd be like, great, that helped me a lot, doc, and can you do the same thing on my feet? I was like, I'm a hand surgeon. but Dr. Dallin, he's a very innovative guy. He's educator to some of the best and brightest, and obviously amazingly, probably just one of the smartest guys I've ever met. He's like, you know, maybe there is something to it. And so he kind of, like, a lot of times they talk about like a glove or stocking distribution for neuropathy. And so he's like, oh, well, look, there's a few nerves in the hand, the median nerve, the ulnar nerve, the radial nerve, and the pattern basically makes a glove after you work on those three nerves. And so he's like, well, the foot's an analogous structure. And so he went to the cadaver labs or dissecting. He's like, oh, there's similar nerve sets in the foot that can be released that will kind of give you that stocking distribution. Yeah. Right. And so he kind of found those areas where it's likely to be pinched, and he did experiments on rats and where nerves were bound and unbound and kind of just, and so he really broke it down, but just in simple terms, it's kind of amazing, because if you talk to, just when I talk to patients and you say carpal tunnel and then same thing can happen in the foot, they're like, yeah, that makes complete sense, right? And so, but unfortunately, in healthcare or with a lot of other doctors, I think just the way we've been trained and conditioned, that's just not it's a hard leap for doctors to make for whatever reason,
Yeah.
oftentimes.
Yeah. So when people come to see you, is there any consistency in terms of their medical history that you see that leads them to a neuropathy? So we often hear diabetes, which you mentioned, that's a common diagnosis, but are there other conditions? Is there dietary things that you see that's correlated with neuropathy? Anything at all?
I mean, there are a lot of things that can cause neuropathy, and a lot of people, the first thing they think of is diabetes, but thyroid can definitely be a factor for diabetes or for neuropathy. I mean, heavy metals and diet can definitely play a role. There's viruses, and so different conditions can certainly cause neuropathy as well too. And so it's really kind of breaking it down into smaller pieces, because I think that's part of the issue too, that I mean, there's big nerves, there's small nerves, there's nerves that control your heart, your skin, your sweat glands. I mean, there's not nerves all over the place. And so until you start breaking smaller pieces, it's really hard to get traction on it. And so I think partly, since I focus below the knee, I think that helps me a little bit, that it's not like neuropathy everywhere. We're just, okay, so how do we kind of help with neuropathy on the top of the foot first, and then we can move to the bottom of the foot or in the leg. And so kind of, I think, break it down to smaller pieces. And like I said, it can be the small nerves in the skin. That's a completely different type of neuropathy, the small fiber neuropathy. It's kind of a different treatment for that. But like just starting with the anatomy, as far as understanding kind of what nerves to go to what areas, a lot of times is pretty insightful.
Okay. And then are there different treatments? So if it's the small nerves of the skin, how do you treat that versus maybe it comes from higher up and it's the tibial nerve that goes down, or one of the other big nerves of the foot?
Sure. And so one of the more successful treatments, I think, for small fiber neuropathy is called neuromodulation. Okay. And so that's a fancy word for nerve reprogramming. And so if you think about it, kind of on a grand scale, the nerves are basically our electrical system, right? And so if you were to, and so the visual that everyone gets and has seen before is when they take paddles out and they shock people's heart, right? And so they don't keep on shocking them, but right, it resets the electrical system. And kind of similar, we can do something similar to that with neuromodulation or electrical stimulation therapy. It's similar to a TENS unit in that it does use electricity, but it's also very different. So a normal TENS unit is about 0 to 2,000 hertz. This is 0 to over 40,000 hertz. And so it doesn't mean that it's an electrical chair or you're gonna like your hair is gonna stand on end, but just kind of cycling the nerves through these different frequencies. A lot of times it can get the nerves to kind of settle down. And I don't think most people realize, but I mean the small nerves in your skin can be very painful. And so like that's why you get a paper cut and there's no blood, and all of a sudden like it stings like crazy, but you don't even see like how does it hurt so much, because there's a lot of fine small nerves that are in your skin. Mm-hmm. So that certainly can be a form of neuropathy that can impact a lot of people.
And then the neuromodulation, is this something they do in the clinic, or is this something that they take a machine home to practice it on a daily basis?
The one we have it's in clinic. And I'm not sure that they're truly home-based options. There's only a couple in the state of Arizona. They're not a lot. It's not a super popular treatment, but it's a pretty powerful treatment. I've had patients that have been to like pretty prestigious places like Mayo Clinic and Barrows Clinic in Phoenix, and have gotten some pretty substantial results with the neuromodulation. So it's certainly a good tool.
Yeah. And then for some of the deeper nerves, are there other treatments besides surgery first, or is it kind of like surgery is the mainstay?
And so certainly some of my mentors like Dr. Dillon have a very high surgical focus. I guess I've sort of blended that and just understanding the anatomy. And so the first step is identifying the nerve. And so, I mean, a lot of times just resetting the nerve, putting some medicine close to kind of calm down the inflammation next to those nerve spots where the nerves being, and so kind of describe it as, like if you're being choked, right? You might get lightheaded, you might get weak, you might feel sick, right? So if a nerve gets choked, it might tingle, it might burn, it might cause weakness, all those kind of things. And certainly it kind of depends on the extent of how badly it's being choked, right? And so I'd say for most people, if you reset these areas, they can do pretty well. And there's multiple sites that these nerves can be compromised, but a lot of times you reset, and I'd say surgical isn't a huge, I mean, it's there for the patients that need it, but it's not most patients, I would say. And so, but it also, and so patients, for instance, that we put the medicine and they're like 90% better or 100% better for 2 days, and it's back. And then, well, that's good in the sense that we at least identify the nerve that's compromised. And then they can feel I can feel more confident too, that if you go to surgery, you have a good chance to get better. And so I think the first step is identifying where is the problem coming from. And that's usually conservative first. And then, then if surgery is needed, and on occasion it is, and that can be done. But so a lot of people will do like NCV testing and EMG testing. There might be some value with that. I mean, generally EMG testing, that's not, for most patients, it's not really the issue that most patients have. And NCV testing can give you some insight, but it's still really not all that therapeutic for most. It's not therapeutic in that it doesn't help them, but maybe it helps identify the region a little bit more.
Right. And some people, when they have information, that helps calm them down a little bit. So I can see some people really like to have that testing done on their muscles and nerves just to find out yay or nay if there's a problem. So I can understand that. Do you also discuss with your patients about lifestyle changes, whether it's footwear or how they carry themselves, anything like that that you have seen that can truly impact these types of nerve injuries or disturbances?
Yeah, I mean, certainly, because there's certainly a mechanical component to nerves as well, let's say. And so for instance, like a lot of times you'll see one of the conservative treatments for carpal tunnel are braces to kind of make sure that you're not overstretching that nerve that goes to the hand and fingers. And so kind of the same thing too is like orthotics to kind of control the motion, how much the foot, part of the foot's function is to absorb shock. And so you want some of that, but to kind of control excessive motion is important, and overstretching, let's say, the nerve as well as tendons. And so, and then also if you have better support from other ligaments and bones, then you're putting the nerve at less, I guess, compromise or irritation.
All right, that makes sense. How much, so when you do orthotics, how much do you look at their shoes as well? Because I know there are such a wide variety of shoes out there, and people wear heeled shoes or dress shoes. Do you try to encourage them to get into more lace-up, athletic shoes that are more cushioned?
Yeah, you have to listen to the patient, right? And so a lot of it is, if they're never going to wear a running shoe, then you don't have to have a huge discussion on it, I suppose. And like, if they're only going to wear sandals, and that's common in Arizona and Tucson at least, and then you have to kind of figure out something that works for them. And so, I mean, a lot of times, generally speaking, I like running shoes. They have a lot of support, a lot of cushion. They're not great if you're going on side to side and playing tennis, I suppose. But for most people, they work pretty well, and you can definitely get a custom orthotic in. But really, it also has to be something that the patients are going to wear. Otherwise, it's not. It's more academic than anything.